In today's episode of FMGE Recall Rush, we have PYQs from medicine that will help you get a quick recap of previous exam. You have 5 seconds before the answer and a quick explanation is shared. We look forward to your feedback in the comments. Let's look at the first question from this video.
Question 1. Which of the following is not a component of child PYQ scoring? Here are the options. A. Albumin, B. Bilirubin, C. INR, D. RFT, and the correct option is D. RFT. Here is the explanation.
What I used to read was the standard child PYQ score, where the components were bilirubin and INR, obviously enjoying their, I would say, important status. But then we were having 3 A's coming up, which are just being mentioned here for practice sake. One would be the values of albumin, and as albumin will progressively reduce, the severity of ascites in a patient will definitely keep on increasing. Initially, it will be medically responsive, then it will become medically refractory as well. And as the liver will get decompensated, the blood ammonia levels will start rising. So there would be a visible flapping tremor or asterixis occurring in the patient. And you will notice that all of these parameters will keep on getting deranged or increased with time, except for the value of albumin, which is one of the important parameters that we anyway use for chronic.
Question 2. A patient presented with a fever for 11 days with neck rigidity. A lumbar puncture was done and it showed lymphocytes predominantly, sugar 50 mg and protein 3000 mg per deciliter. Gram staining was negative. Chest X-ray of the patient shows upper lobe involvement with hilar lymph node enlargement. What is the probable diagnosis? Here are the options. A. Tuberculous meningitis, B. Bacterial meningitis, C. Fungal meningitis, D. Viral meningitis. And the correct option is A. Tuberculous meningitis. Here is the explanation.
Lots of time in Indian exams, they love to ask about tubercular meningitis. The picture would be identical in a sense that pressure would still be increased because choroid plexus irritation would cause more production of CSF, but the cell picture in this case will mainly be lymphocytes. Because it's a chronic inflammation, most of the time you will be noticing something in the range of 100 to 1000. L stands for lymphocytes per cubic millimeter. The CSF sugar will always be low but will never ever be zero. As I highlighted, CSF sugar can be zero in acute bacterial meningitis, unmeasurable. When you check up the proteins are going to be grossly elevated. In fact, if you take the CSF sample of a person of tubercular meningitis in a test tube, you let it stand for a while, you will notice that the proteins will begin to clot like a basketball net. You can see in this case, I've shown the proteins forming a clot or a plug inside the test tube, which is hanging in the test tube upside down like a basketball net. And the technical term that they use for this is called as cobweb coagulum. They love to actually ask about this cobweb coagulum, and micropeople are very fond of cobweb coagulum. Why? Because the bacteria will get trapped inside this, and once the bacteria get trapped inside this cobweb coagulum, in those circumstances, well, you can extract this and subsequently you can use this cobweb coagulum per se for ZN staining, LJ culture media plating, and even for performing CB-NAT investigation. Tubercular meningitis can be frequently asked to you. Let's just put in the data in the right perspective for this topic as well. In tubercular meningitis, when you will integrate this with pathology, you need to remember regarding rich focus. When we talk about the history per se, from the history perspective, I want you to remember that it would be a long-standing history of illness for a few weeks. What is the problem? The child is becoming irritable. He is not eating food. The mother is worried that he keeps on sleeping for most part of the day. Whenever he wakes up, he does not eat. And child cannot say headache, no, so he might bang his head against the wall. The child is mostly drowsy, irritable. He was a very playful, cute, cuddly child, but now the behavior of the child has changed and the mother is noticing it. In fact, every mother, educated or uneducated, definitely make out her child is sick. Gradually, she is noticing that the child is not able to even recognize her. Altered sensorium and the oral intake has practically become zero. At this point of time, there might even be episodes of focal seizures because of which they showed some local RMP doctor, no improvement. Then she is noticing that the child is not even moving his legs. There might be monoplegia because in tubercular meningitis, there is end arteritis also. the blood supply of the cortex can be hampered. So you could be having mini strokes. There could be multiple mini strokes happening. Why? Because I said the lesion could be end arteritis, damage to the blood vessels of the brain by the TB bacilli. There could be monoplegia, there could be paraplegia, depending on whichever part is damaged. And yes, the findings of meningeal irritation, that is nuchal rigidity, will also definitely come into being.
Question 3. Which of the following is a cause of exudative pleural effusion? Here are the options. A. Heart failure, B. Liver failure, C. Rheumatoid arthritis, D. Nephrotic syndrome. And the correct option is C. Rheumatoid arthritis. Here is the explanation.
I'll try to explain manifestations of rheumatoid arthritis patients from top to bottom. The joint part I've already highlighted. I'm mainly focusing on the extra-articular manifestations. You could be having eyes involvement. Traditionally, in most autoimmune disorders, you will read about eye involvement of uveitis. Like for example, in sarcoidosis, you have non-caseating granulomas. They cause uveitis, but you do not read about uveitis in rheumatoid arthritis. Instead of uveitis, what you read here is keratoconjunctivitis sicca, which is the commonest ocular manifestation of this patient. Otherwise, you could even be having a scleritis component or episcleritis, which could be written. Worst can be even a scleromalacia perforans. So bad news here in a sense that you could be having a damage pretty substantial to the sclera, that there is even a perforation occurring. Very classical terminology, even taught in ophthalmology as well. This question has been asked multiple times. Ocular manifestation of rheumatoid arthritis. He basically wants you to think in terms of uveitis, whereas it's gonna be scleritis, though the commonest one is dry eyes, keratoconjunctivitis sicca. Because this damage can occur even in the salivary glands. So saliva production is compromised, so xerostomia developing in the patient. Then in the cervical spine, I've already highlighted the problem of atlantoaxial dislocation, which will occur in future. So you need to rule them out from getting recruited into forces or police, for that matter of fact that they won't be able to do their job and will hurt themselves. Now I will describe what's gonna be the lung manifestations of these patients. He can either write pleuritis, because this is inflammatory nodule causing a pleural rub, or multiple nodules. And when they break down, you could be having blunting of the costophrenic angle on a chest x-ray of these patients, primarily because there's a pleural effusion component coming up.
Question 4. Absent P wave, a wave is a feature of which of the following? Here are the options. A. Ventricular tachycardia, B. Focal atrial tachycardia, C. Ventricular fibrillation, D. Atrial fibrillation. And the correct option is D. Atrial fibrillation. Here is the explanation.
I am describing a condition in which fourth heart sound can never ever be seen because the poor atria are twitching. The commonest arrhythmia in clinical practice, the commonest sustained arrhythmia in clinical practice is atrial fibrillation, because the atria is gonna be twitching. There's no forceful contraction. Forget about forceful. There's not even a normal contraction happening. So it's gonna be twitching, contributing to, the twitching cannot generate power. So it's gonna be an absent fourth heart sound in a patient. In fact, this also gives me leverage to mention that in atrial fibrillation, the dominance of the heart, normally we talk about that SA node is the dominant pacemaker, but in atrial fibrillation, it is the ectopic foci which are the dominant pacemaker. SA node per se is not gonna be a dominant pacemaker. As the result of it, even in atrial fibrillation, the first wave of the ECG will be absent, P wave will be absent. Similarly, the first wave of the JVP is the A wave. A wave is due to atrial systole, though I'll be drawing diagrams of JVP also before you, but all of you know from physiology that A wave is due to atrial systole, and in atrial fibrillation there is no atrial systole because atria are twitching. So even the first wave of the JVP will be absent. So you can see that three things are absent in atrial fibrillation. You can remember it like this. The commonest arrhythmia in clinical practice, you do not get the first wave of the ECG, you do not get the first wave of the JVP, and you can never ever have a fourth heart sound in these patients.
Question 5. A young male patient presents with ptosis which reportedly worsens in the evening and improves in the morning. He also complains of excessive fatigability towards the end of the day which improves with rest. Placing an ice pack over his eyes significantly decreases ptosis. What is the most likely diagnosis? Here are the options. A. Myasthenia gravis, B. Huntington chorea, C. Amyotrophic lateral sclerosis, D. External ophthalmoplegia. And the correct option is A. Myasthenia gravis. Here is the explanation.
The earliest manifestation in these patients is development of ptosis and involvement of the extraocular muscles. Do appreciate the fact that myasthenic weakness is more in the evening hours as compared to morning hours. There will always be a diurnal variation of history given in this question. Weakness and fatigability are two very non-specific terms. If you're lazy, you might say, I am weak, I am fatigued. But if you read a question that describes the words that I said, that patient is okay in the morning, but by evening hours there is development of symptoms. If diurnal variation is described in a question, that definitely tells you that you bang on track for diagnosis of myasthenia gravis.
Question 6. Tall and tented T waves, scent elevation, and absent P wave are features of. Here are the options. A. Bundle branch block, B. Acute MI, C. Hyperkalemia, D. Ventricular ectopic. And the correct option is C. Hyperkalemia. Here is the explanation.
Hypokalemia 1, I've told you that because the arrow is going up, the T wave height will also go up. So this is gonna be tall tented T waves, and ST is gonna follow it, so ST elevation. The counterpart information will be on the opposite side. The T wave amplitude will reduce and will become absent, and concomitantly there will be ST segment depression developing in the patient. On the left hand side, the P wave in the ECG will begin to disappear, whereas on this side the amplitude of the P wave will start to rise in the absence of pulmonary artery hypertension, so I'm going to call it a pseudo P pulmonale. Then a new wave that can be generated here. What I mean by new is that it would be becoming prominent, that is prominent U wave. Otherwise U wave can be found in ECG of a normal person as well. The common information between the two is PR prolongation, which is seen with both because potassium gradients will affect the conduction from SA node to the AV node.
Question 7. A 40-year-old female patient presents with cold intolerance, dry skin, constipation, and on examination slow ankle jerk with a TSH level of 15 IUL and low T3 and T4. Of the following, the next best step in the management of this patient is to. Here are the options. A. Begin treatment with levothyroxine, LT4. B. Measure thyroxine binding globulin, TBG. C. Order a thyroid radionuclide uptake and scan. D. Order thyroid ultrasonography. And the correct option is A. Begin treatment with levothyroxine, LT4. Here is the explanation.
I shall now be comparing this discussion of hyperthyroidism with the counterpart opposite effect, that is hypothyroidism. The discussion will be divided similarly into two parts, that is primary versus secondary. Let's work out the causes and the laboratory reports seen in these patients. Primary would imply that the problem lies in the gland of this patient, whereas secondary would imply that the problem lies in the pituitary. Well, if the gland will malfunction, then the production of T4 and T3 both will be reduced, and by feedback mechanism, the TSH of the patient will start getting elevated. The clinical features of this disease will evolve. Since the thyroid hormones play an important role in basal metabolic rate, the basal metabolic rate in this case is downgraded, so there would be a weight gain in the person. However, it is not an extensive weight gain, it's only a modest weight gain that will occur in the patient. Unlike Cushing syndrome, where patient will put on lots and lots of fat and a centripetal obesity, here the weight gain is relatively on the lower side. The calorigenesis component will also be reduced, so that is why the patient will not be comfortable in the winter months. Cold intolerance. The moment these terms are written, it is very unlikely that you will ever mess up on the clinical diagnosis of hyper and hypothyroidism the way the question is presented. Myxedema is an integral component of both hyper as well as hypothyroidism. In hypo, it can occur over the scalp. Therefore, you will notice significant alopecia. Let me say female patient, she is combing her hair, brushing her hair, she is losing lot of hair. You see glycosaminoglycans which are present in the myxedema component, they tend to trap a lot of water. Therefore, there would be swelling in the tissues. So therefore, myxedema, if it is going to involve the face of the patient, you will read about puffy face. That's going to be a cosmetic complaint of the patient. If the myxedema involves the vocal cords, there would be a voice change. There would be hoarseness of voice, or if you are speaking to this patient, let me say over a telephone, it will sound like a man's voice, like a woman's voice will become very throaty and heavy, so it will sound like a man's voice. There is a upgrade of total peripheral resistance. So the blood pressure of this patient is elevated, and when you take the BP recording, you will be surprisingly finding systolic to be normal and diastolic to be elevated. You will be finding isolated diastolic hypertension. The statement of mine is isolated diastolic hypertension is found in hypothyroidism. That does not mean that it is one of the common causes. Obviously, if they ask you what causes isolated diastolic hypertension, the first answer is essential hypertension. If that is not present, though it's the commonest one, then it is what we are talking about, hypothyroidism. Apart from this, you will also read about isolated diastolic hypertension developing in Conn syndrome and even in Cushing syndrome. The number one cause I've highlighted is essential hypertension. It's obviously a diagnosis of exclusion. I mean, hypothyroidism, Conn and Cushing has to be reduced in these patients, and hypertension per se is going to contribute to headache on a daily basis. The person might ascribe that to office stress. There will also be an increase in gut motility of these patients there will also be a change in the gut motility of this patient, which will explain the constipation component. To the treatment of these patients, the standard treatment is levothyroxine. This has to be given on a lifelong basis in both primary as well as secondary hypothyroidism.
Question 8. A 55-year-old construction factory worker presents with dyspnea. He has been working in this industry for the past 25 years. Which is the most specific malignancy that we can expect in this patient? Here are the options. A. Adenocarcinoma of lung. B. Malignant mesothelioma. C. Small cell carcinoma of lung. D. Squamous cell carcinoma of lung. And the correct option is B. Malignant mesothelioma. Here is the explanation.
The mesothelioma, which is associated with asbestosis, can not only be having a pleural plaque calcification but can be having a hemorrhagic pleural effusion. So I'm writing it vice versa also. Mesothelioma, the MCQ said which condition will cause pleural plaque calcification. Very straightforward. That is going to be mesothelioma. And then he mentioned regarding bloody pleural effusion present in this case, which is definitely the case.
Question 9. Pulsus paradoxus is seen in? Here are the options. A. Coronary artery disease. B. Acute severe asthma. C. Restrictive cardiomyopathy. D. Right ventricular myocardial infarction. And the correct option is B. Acute severe asthma. Here is the explanation.
Now, since lots of us are able to retain this information deliberately in the MCQ, he may not be having cardiac tamponade as one of the causes of pulsus paradoxus. He can actually put up another cause per se. And another cause that I want you to remember for pulsus paradoxus per se can be status asthmaticus. He can write status asthmaticus, he can say severe acute asthma. See, respiratory conditions, they can deliberately introduce in the MCQ, because he knows that your thought process or you are focused on cardiology, so he'll try to incorporate respiratory condition in the question.
Question 10. Takaisu arteritis most commonly involves. Here are the options. A. Pulmonary artery. B. Coronary arteries. C. Abdominal aorta. D. Arch of aorta. And the correct option is D. Arch of aorta. Here is the explanation.
The problem is not in the valve cusps. The problem is not in the chordate tendineae. The problem is with respect to the aortic root per se. There is a aortic root dilatation that is occurring, and because of this there will be a dilatation of the annulus. So per se there is no shortening of the cusp. It is the annulus getting dilated which is contributing to aortic regurgitation. So let's have reasons for it. One of the important reasons would be simply inflammation in the root of the aorta, aortitis. So he can ask you what is the reason behind development of this aortitis. Then your answer would be Takayasu. You see, Takayasu can not only contribute to involvement of the left subclavian artery and can cause unequal BP between left and right arm. It can even cause renal artery stenosis. It can even cause aortitis as well, and subsequently aortic regurgitation.
Question 11. A 60-year-old woman who recently received a kidney transplant 2 months ago develops a high fever and severe dyspnea with a dry hacking cough. Chest X-ray reveals bilateral interstitial infiltrates that are diffuse and histopathological seen basophilic intracytoplasmic and intranuclear inclusion bodies. Which of the following agents is most likely responsible for her condition? Here are the options. A. Adenovirus, B. Cytomegalovirus, C. Influenza virus, D. Respiratory syncytial. And the correct option is B. Cytomegalovirus. Here is the explanation.
Cytomegalovirus. One, you can make out this is gut intestine. Why? Because you can see the goblet cells here. These are the goblet cells which are highlighted. And then you can notice, if I just zoom in, a cell which is having basophilic inclusion bodies. So cytomegalovirus is usually identified by basophilic intracytoplasmic as well as intranuclear inclusion bodies, and we especially have some stains by which we can identify the cytomegalovirus infected cells, which can be used obviously to pick up the infection.
Question 12. A girl presented with prolonged menstrual bleeding and her investigations showed normal platelet count (PT) and APTT while bleeding time was increased. On further analysis, defect in chromosome 17 was found. What is the most likely diagnosis? Here are the options. A. Bernard-Soulier syndrome, B. Glanzmann thrombasthenia, C. Hemophilia A, D. Von Willebrand disease. And the correct option is B. Glanzmann thrombasthenia. Here is the explanation.
Glanzmann thrombasthenia will present. In fact, the MCQ of Glanzmann thrombasthenia and Bernard-Soulier can notoriously look the same. So one of the important topics that are being discussed at the moment is the comparison between the two. Once you're done listening here, I want you to listen to mainly Bernard-Soulier and Glanzmann thrombasthenia again so that you can pick up the subtle differences. You see, receptor problem, I don't anticipate that you will mess up on the receptor. That I am very sure all of you guys are highly intelligent chaps. You can easily pick it up. It is mainly the subsequent issues that I'll say that can cause a bit error of judgment. You see, the receptor that I'm talking about at the moment would be called as 2b beta 3 receptor, and the main function of this would be that it is responsible or it helps in platelet aggregation. Now, this is an autosomal recessive condition. The defect is on chromosome number 17, and he might mention information regarding marriage between cousins, that is consanguineous marriage information can be given in the question before he starts describing the manifestations, which will be an aid to diagnosis because you know that there's something genetically wrong contributing to bleeding. Previously I was talking about genetic problems related to bleeding in the form of hemophilia, then I spoke about Bernard, and now Glanzmann thrombasthenia is there. You see, the textbook uses the following phrase to describe the problem here. He says there is both a qualitative, in this case he says there is both a qualitative as well as a quantitative deficiency of this receptor. Last time I was focusing only on the quality part. Here I'm saying two things are defective. Both the quantity part and the quality part of this particular receptor is gonna be defective in this case, and therefore the question will describe the standard presentation of excessive post-operative bleeding. Before I write that statement, he might actually try to bluff his way across and waste your first 30 seconds of the MCQ by talking about menorrhagia, maybe gingival bleeding that might make you think in terms of possibility of scurvy or hematological malignancies like AML, ALL, which can again have a gingival bleed. He might distract you by describing a person having hematochezia and you might be thinking of surgical causes, or he might say recurrent epistaxis so that you start thinking in terms of ENT causes. All these are distractors. And then he'll come to the main fact that this guy, he underwent some kind of a minor surgery, and then there is an excessive post-operative bleeding occurring. Now, because the history can definitely look the same in both of the diseases, we need to be sure about which one to answer based on the workup. In this condition also, the platelet count will turn out to be normal. However, I will suspect there's something wrong with the platelets. Why? Because the coagulogram of this patient will definitely be defective. The bleeding time would still be increased. In this case, the peripheral smear will not reveal anything abnormal with respect to the size of the platelets. So earlier I was vocal about saying that size of the platelets can give you a hint regarding the diagnosis. In this case, the question will be silent or will just mention platelets appear adequate on a peripheral smear. The coagulogram will sensitize you to the fact that there is something wrong with the function of the platelets because bleeding time is elevated with a normal platelet count. Traditionally, when platelet count becomes lesser, that is when bleeding time will rise. But in this case, bleeding time is elevated and the remaining parameters are normal. So you definitely need to go.
Question 13. The lab reports of a 40-year-old man show positive IgG anti-HBC and negative HbSAg. What is the most likely diagnosis? Here are the options. A. Recovering from hepatitis B. B. Hepatitis B in the remote past. C. Immunization with HbSAg. D. Both B and C. And the correct option is B. Hepatitis B in the remote past. Here is the explanation.
To be remembered by you would be antibody against the surface antigen, which is anyway the protective antibody. Then is antibody to the core antigen. And the third one would be antibody to the E antigen. And before I formulate a table before you, it's important to understand the importance. You see, antibody to surface antigen will develop even in an individual who has received a vaccine and also a person who has recovered from hepatitis B, because I told you in majority of cases recovery will occur on its own. But if he talks about antibody against the core antigen, he would like to talk about two aspects, IgM class of antibody and IgG class of antibody. If you read IgG class of antibody to the core antigen with surface antigen positivity, it means that the patient is having chronic hepatitis B, understandable, IgG chronic. But when you will read about IgM class of antibody with surface antigen, you will notice that in multiple choice questions, sometimes the answer is given as acute hepatitis B and sometimes the answer is given as gap period.
Question 14. A 53-year-old patient is brought to the emergency room with altered sensorium and rapid shallow breathing. His abdomen is distended with palpable hepatomegaly and splenomegaly and sclerae are icteric. The other examination findings are given below. Laboratory tests show that the AST-ALT ratio is 3:1. What is the most likely cause of this patient's presentation? Here are the options. A. Alcoholic liver disease. B. Acute viral hepatitis. C. Autoimmune hepatitis. D. Acetaminophen poisoning. And the correct option is A. Alcoholic liver disease. Here is the explanation.
This table specifically mentions regarding alcoholic fatty liver and alcoholic hepatitis and mentions that the test to be done is SGOT. I've told you the values already, but I had to show you this table just to prove to you the fact that gamma GGTP, though it is a marker for heavy alcohol consumption, he mentions the fact that it is not specific to alcohol, it is easily inducible, it can be increased in all forms of fatty liver, even it can be increased in patients of non-alcoholic steatotic hepatitis. So
Question 15. A 50-year-old man presents with recurrent episodes of chest pain which is seen on exertion or exercise and lasts 2 to 5 minutes. He was assessed and was diagnosed with a case of chronic stable angina. What is the most appropriate antihypertensive for this patient? Here are the options. A. Metoprolol. B. Thiazides. C. Enalapril. D. Amlodipine. And the correct option is A. Metoprolol. Here is the explanation.
Now I've given you sufficient time to ask you what is the drug of choice for chronic stable angina, and the bottom line is that this drug that I'm going to mention has been shown to reduce mortality. And when the answer will be a simple and a straightforward beta blocker, we have been using for a very long duration metoprolol, or we have newer derivatives like carvedilol available. But the objective is that when we will give metoprolol to the patient, it will reduce the heart rate, it will reduce the oxygen consumption of the heart. And if you downgrade the oxygen consumption per se, you will definitely be able to enhance the productivity of the heart per se. So metoprolol and aspirin both are mortality reducing drugs, but on a comparison basis, if he says the word, and mark my words there, if he says what is the major mortality reducing drug in chronic stable angina, your answer would be given as beta blockers, that is.
Question 16. A 66-year-old patient presents with swelling of the ankle for the past 3 months. Urine examination shows heavy proteinuria. Urine microscopy shows oval fat bodies. Diagnosis. Here are the options. A. Focal segmental glomerulosclerosis. B. Membranous glomerulopathy. C. Membranoproliferative glomerulonephritis. D. Minimal change disease. And the correct option is B. Membranous glomerulopathy. Here is the explanation.
So today in my outpatient department, I have this 65-year-old gentleman. He came to me because he's having puffy eyes, and he also says that I am having problems with wearing slippers in my slippers or shoes in my feet because there is a concomitant pedal edema also present. And he also says that the body feels relatively more puffy. So any of these descriptions can be written. Either he will just say anasarca, or he will describe this puffy eye appearance. And he's also having headaches, which are pretty severe. So I decided to check his blood pressure on the lieu of the swelling in the body. And I noticed that he was having blood pressure values in excess of what his age should be. So considering all these facts, along with this maybe foamy urine, though I mean this word may not be described or noticed by the patient initially, because most patients who come to me initially with MGN, I will be considering the age of the patient and think that there must be a cardiac cause. So most of the time, initially, I might be doing a echocardiography of this patient. I might get a baseline ECG of this patient, because I thought there must be cardiac reason. Hypertension, puffy eyes, I'll think that, okay, hypertension has become relatively more severe. So there's a possibility he's having a heart failure, and that heart failure is contributing to the edema component. So foamy urine as a feature is something that a patient may not even appreciate, or you may not even ask also. So most of the time, initially, when these patients come to you, you might think that it's a cardiac case, and the workup of these patients will subsequently reveal that this particular chap is, yes, the heart will get involved in these patients anyway, because they're geriatric age patients. If they're having chronic stable angina, and over and above this the kidney gets involved, the cardiac lesion will anyway be affected also. But what is catching my attention is the grossly deranged KFT of this guy. So I first thought that he's having cardio-renal syndrome, because you see, if the heart is involved, then ultimately kidney is getting involved also. But when I'm looking at the reports, then I'm finding some rather some clues to the fact that this is not the heart contributing to kidney involvement. It is actually the kidney which is at fault, and then subsequently maybe the heart will also get involved because of the hypertension component and coronary artery disease, which can anyway occur in old age. Now, on urine microscopic examination, the pathologist mentioned the report saying oval fat bodies, and they also used the polarizer, and therefore Maltese cross appearance was also described. So traditionally, when you are evaluating any, not that I'm saying that Maltese cross is something very important from diagnostic purpose, but yeah, from the exam perspective, that this is definitely what is to.
Question 17. Malignant hypertension can lead to all of the following except. Here are the options. A. Hypertensive retinopathy. B. Respiratory failure. C. Renal failure. D. Encephalopathy. And the correct option is B. Respiratory failure. Here is the explanation.
And in malignant hypertension, the target organ damage could be in the form of retinal hemorrhages occurring in the person, or it could be putaminal bleed, intraparenchymal bleed. It could be nephrosclerosis, and the person's kidney status has deteriorated.
Question 18. A 65-year-old female patient presents to the OPD with complaints of shortness of breath and tiredness. On examination, increase JVP on inspiration, steep X and Y present. Which of the following is the most likely diagnosis? Here are the options. A. Constrictive pericarditis. B. Cardiac tamponade. C. Dilated cardiomyopathy. D. Restricted cardiomyopathy. And the correct option is A. Constrictive pericarditis. Here is the explanation.
What should be given in a multiple choice question over and above the features which have been highlighted here, which will tell you that, okay man, this is not gonna be a plain congestive heart failure, this is constrictive pericarditis. The first one I've already sensitized you to. This is pericardial shudder. This is discussed even in the topic of heart sounds. Pericardial shudder is occurring almost at the same time as the third heart sound. The alternative names are knock and shock. As I've highlighted, pericardial shudder is a diastolic event. I'll just draw a sketch here to highlight what I mean by the word pericardial shudder in this case. Let us take this to be the, I would say, the cardiac muscle. And when the blood will strike this cardiac muscle in a normal person, the heart can definitely dilate. You see, the cardiac fibers in you and me are definitely gonna be contracting, but they're elastic also in a sense that they can accommodate the blood. So as contrast to a normal individual, the person that I'm discussing at this scenario, you see, this is the thick calcification. It's a very irregular calcification that will encase the heart from outside like an egg shell. So when the blood comes into the heart, it will hit the muscle. It will try to dilate the muscle. But at the last movement, you can see, because of the encasement by the calcified sac from outside, the blood will not be able to cause a substantial normal distension of the heart like it happens in you and me. The blood is hitting the muscle and then is bouncing off. Why? Because there is a non-compliant ventricle. This non-compliant ventricle is because of the thick zone of calcification outside, and this bouncing of blood against a non-compliant ventricle will set off a turbulence, and this turbulence is what is picked up by a stethoscope as pericardial shudder. Another feature that can be given to supplement what I have just said would be Kussmaul sign. In fact, Kussmaul sign has been discussed a couple of times, so should be relatively easy for you. I have taught you that Kussmaul sign is what we see with constrictive pericarditis, restrictive cardiomyopathy, and right-sided myocardial infarction. In fact, Kussmaul sign is elevation of JVP on inspiration. I'm just writing that in bold to highlight that in a normal person, JVP should be falling on inspiration. Additional information that will be given will be steep X and steep Y. I hope you recall in JVP lecture I've told you if it is steep X and absent Y, it is cardiac tamponade, whereas if you get both steep X and steep Y, this is going to be constrictive pericarditis. Additional information to be remembered is because atria will be working with stiff ventricles. I repeat the word here. There is stiffness outside the heart. Why? Because there is a substantial amount of calcification. So when the blood will try to enter during atrial systole, the atria are working harder because of the stiffness around the heart. So therefore this person will also be having S4 present. I repeat the fact again, why S4 is present is because the left atria is having to work against a resistance.
Question 19. Identify the deformity depicted in the image. Here are the options. A. Swan neck deformity. B. Boutonniere deformity. C. Z-line deformity. D. Trigger finger. And the correct option is B. Boutonniere deformity. Here is the explanation.
Be in the same hand in a different finger. So I mean you could be having a swan neck deformity and a boutonniere deformity in the same person in different fingers of the hands. Now you will notice the fact that when it comes to proximal interphalangeal joint and then when it comes to distal interphalangeal joint, here the situation is reversed. Earlier the words that I said was PIP was having an extension. I repeat the statement, you can see on the slide at the moment, PIP is having extension, but if you look at the boutonniere's deformity component, the PIP of the patient is rather having a flexion. So at the moment it might look easy for you, what's the big deal, but in the exam when he's gonna write no flexion extension for the proximal and the DIP joint, lots of people tend to mix this up in the exam and they might actually miss the statement. He can interchange the information also, no? The bottom line is the interchanging should not occur. So you need to keep your mind very clear. For swan neck deformity, there's gonna be a PIP having extension and the DIP having a flexion. If you get that, just invert the data and that would be boutonniere's deformity.
Question 20. A 50-year-old man presents to you with features of anemia, fever, and recurrent nosebleeds. On examination there is hepatosplenomegaly. Lab investigations revealed Hb is equal to 6 gram per deciliter, TLC count is equal to 40,000 per cubic millimeter with 10% blasts and platelet count is equal to 12,000 per cu.mm. On further investigation, T821 was detected in the blasts. What is the diagnosis? Here are the options. A. Acute lymphoblastic leukemia. B. Acute myeloid leukemia. C. Preleukemia. D. Aleukemic leukemia. And the correct option is B. Acute myeloid leukemia. Here is the explanation.
One of the biggest problems that we encounter as a physician while managing this patient can be an extremely high TLC count that will contribute to leukostasis, which implies that there would be a sluggish circulation due to increase in the cell count. Secondary to the hyperviscosity, there's a possibility that this guy could be having acute coronary syndrome. They can be stroke-like manifestations, priapism, even in fact, lungs can be involved. So you could be having respiratory distress, and the Glasgow coma scale of this patient will drop because there was a problem with the brain circulation of the patient. In a multiple choice question, if they ask you regarding leukostasis, then obviously you will answer both for acute as well as chronic myeloid leukemia. But in chronic myeloid leukemia, as I've explained to you, once the patient will go into blast crisis, that is when you would be having a development of leukostasis, where in acute myeloid leukemia, it could be rather early on in the development of the disease. The second big problem that we see with this cancer is possibility of development of DIC. Autosomal translocation that they love to ask is 8:21. Now I'm putting an old name. I'll erase this name subsequently because nowadays the medical literature does not support the use of the word chloroma. Nowadays the word that is used is myeloid sarcoma, but it presents as, I think if you're using the older version of even pathology books, you will notice an image of a child with unilateral proptosis, a kid with a big eye, unilateral proptosis, that is chloroma. So chloroma is related to T8:21 translocation. Because it's an old term, I have erased the name here. The current name I'll write subsequently in the clinical domain is myeloid sarcoma. The chromosomal swap in this case will result in development of, again, I said, a fusion product. And let's look at the name for the fusion product, pretty fancy name, that is X1T1. So they expect you to remember these fancy aspects also.
Question 21. A 26-year-old male with a history of respiratory tract infection 4 weeks ago is unable to stand or walk for the past 2 weeks, and the weakness is progressive, ascending, and symmetrical in nature. The lower limbs were involved before and gradually the upper limbs were also affected. On examination you note aflexia. Pain is preserved. What is the probable diagnosis? Here are the options. A. Guillain-Barre syndrome, B. Myasthenia gravis, C. Polymyositis, D. Multiple sclerosis. And the correct option is A. Guillain-Barre syndrome. Here is the explanation.
Definitely have a clinical recovery from the current illness per se, that is the dysentery component. Neither this patient knows at the moment and neither do I know what is going to happen to this patient subsequently, and therefore something like about 2 to 4 weeks later, that is when this person will develop neurological complications. The bad news about the disorder is that it can occur suddenly. From the patient's perspective, I'm saying suddenly because he cannot obviously correlate that the previous gastroenteritis/dysentery episode is the trigger which is resulting in antibodies, and then a type 4 hypersensitivity working in sync resulting in demyelination. The initial presentation of this guy will be that of weakness in both his legs. Like this guy is young guy, maybe 25-30 years of age. He woke up in the morning and he's not having any power in his legs. Now think from a non-medical's perspective, if a person wakes up with less power in his legs or he can't move his legs, he might think that he might have slept in some wrong position that resulted in compression of some nerve, which is resulting in him having this difficulty in moving his legs per se. So he may be called out to his mom or maybe called out to his dad, and you have to think this from a perspective of non-medical, right? And they're rubbing his legs, or maybe they're applying some oil over his legs. His mom is rubbing the soles of this guy because she's scared. My son woke up in the morning and he can't move his legs. There would be flaccid paraplegia to the level that this guy will not be able to stand up, and if he takes the support of his arms, because at the moment the power is not lost in the arms, he might actually try to raise from the bed using the support of his arms, but when he will try to stand, the legs will not be able to rather take the weight of the body because there is flaccidity and this guy is gonna fall. This is going to be definitely emotionally a very sad perspective for both this patient as well as this person's parents as well, and he would be rushed to the hospital. There's a possibility that his mother or sister or brother is telling you when he's brought to the hospital after a few hours that at least in the morning he was not having any power in his legs, but by evening, by the time they reach you, there's a possibility that he cannot even sit in the chair. You see, like you and me can sit in the chair because our truncal muscles are able to maintain the posture. But in this case, because even truncal musculature will undergo flaccid paralysis, so therefore this guy will tend to, maybe fall on one side, and you will have to put pillows behind the back of this guy to ensure that at least he's able to sit. The disease will progress now even so fast that there can be even arm paralysis developing in this guy. And if biceps is paralyzed, that is bad news, because one of the root values of biceps is C5. You see, the root value of biceps is C5, C6. If C5 is involved, this means that the demyelination is occurring in the cervical part of the spinal cord, and C5 shares a common root with the phrenic nerve also. So once the arm weakness will develop, I am really worried about this guy, not only because he has developed a fast onset quadriplegia in a matter of, let me say, 24 hours. I am worried about this guy because I think and that my worst fears will definitely come true, because these patients will end up with diaphragmatic paralysis. In fact, I want to say that biceps weakness or biceps paralysis in a Guillain-Barre syndrome patient actually tells you that the disease has progressed to the cervical spine. The demyelination will obviously occur in any area of the spinal cord. You see, you will lots of time see the pathologist using the term segmental demyelination. I'll use this term subsequently also, but I just want you to remember this term because this helps you rather relate to the manifestations relatively better, that there's a patchy involvement. Like for example, I might say later bladder and bowel are spared. So you might say, sir, how is it possible if you're saying demyelination? Because it is patchy. So bladder and bowel may not be involved also. Segmental demyelination helps you understand the disease manifestations relatively better, and unfortunately this guy has now been admitted into my intensive care unit. We have electively intubated the person and put him on positive pressure ventilation, and in some cases, because recovery might be delayed, you might even have to do a tracheostomy in this guy. And lots of time in our country, due to lack of medical facilities, you see, if he is not intubated on time, the carbon dioxide values in the body will continue to rise. This will contribute to development of respiratory acidosis. And why am I scared about acidosis is because acidosis can damage the blood-brain barrier, contributing to brain swelling and encephalopathy. Acidosis can damage the heart, contributing to arrhythmias. If the patient is not given ventilatory support, these patients can actually expire due to type 2 respiratory failure, which is secondary to the diaphragmatic paralysis. You can see the person is having hypoventilation now. And it is not the end of the story. The paralysis will obviously extend very fast. Now there's a possibility that even there might be neck weakness developing in this guy. And this is not the end of the story. There's a distinct possibility that in this same individual, now there would be development of neck floppiness. Like you can study in the library for the whole day, or you're sitting in your house, in your room, in your table and chair, and you can study the whole day because your neck muscles are so strong that you can sit like I am sitting at the moment, and I can focus in the computer screen in front of me. But in this case, there would be a distinct neck floppiness that would be occurring, and subsequently he can ask you which cranial nerve is involved in this condition. You would notice that in GBS there's a possibility of patient developing a bilateral seventh nerve palsy. You are aware of the fact that Bell's palsy is the unilateral seventh nerve palsy, but here I have used the word facial diplegia. Medical disorders where you read about facial diplegia could be sarcoidosis, non-caseating granulomas involving the seventh nerves bilaterally. Then can be Melkerson-Rosenthal syndrome, and then is the topic that we are studying, that is Guillain-Barre syndrome. In fact, the infective cause that I'm not writing at the moment, but you will notice me writing subsequently, is Lyme's disease, because at the moment I don't want to get into another infection and then say that it's going to cause neurological manifestations. I want you to remember that the most common cranial nerve involved in sarcoidosis is also the seventh nerve, and the most common cranial nerve involved in Guillain-Barre syndrome also happens to be the seventh nerve. Subsequently, even feeding problems will occur in this person. The same patient will not be able to, let me say, sip tea or coffee, or let me say his mother gave milk to this guy, right? She put haldi in that milk. Like, you know, if somebody falls sick in India, what they do is they put haldi in milk and they think that it will give strength to the person, right? Turmeric. So she tried to give something to the child and it's coming out of the nose, or he might even aspirate and die. So bulbar palsy can definitely occur in these patients. The manifestations of bulbar palsy can be that if the 9th cranial nerve, the 10th nerves, and especially the 12th cranial nerves are involved, the lower motor neuron lesion related to these nerves will definitely cause problems in talking, problems in speaking, problems in especially drinking. So when you read the word can't drink, can't eat, can't talk also. Why? Because vagus nerve is gone. Vagus is going to be controlling the voice box. So this person will definitely now be in a dicey situation, to the risk of even developing aspiration pneumonia, especially if somebody in the family tries to give something to him. Like, you see, it's hot in India sometimes, and the family member might think that we have not given him even water to drink for one day. We have just shifted him to the hospital and doctor is not allowing anything orally. So they might just put little bit of water in the mouth of the patient at night, and the patient can aspirate and die. And you all have experienced this so many times in your hospitals when especially the patient's relatives do not listen to you. The next problem can be autonomic insufficiency. Well, in this particular disease, yes, you can have sensory manifestations also, you can have autonomic manifestations also. So let me explain both of them. Do not be under impression, mark my words there guys, don't be under impression that this is only a pure motor disorder. There can be sensory involvement also, there can be autonomic involvement also. Let me explain to you what I mean by the word autonomic insufficiency here. Fibers from T1 to T4, they are called as cardiac accelerator fibers. Like, for example, if I request you, the doctor, can you do 5 sit-ups or 5 push-ups? You guys are young people, so doing few sit-ups or push-ups is no big deal for you. But when you will do sit-ups or push-ups, then your heart rate will increase. What will increase your heart rate? The sympathomimetic drive that is coming from T1 to T4 via the cardiac exciter fibers can increase your heart rate. But in this case, because these fibers are demyelinated, these fibers are damaged, so you will notice that these patients can be having bradycardia. Because of this bradycardia component, the BP will also be low. So one, I can use the word neurogenic shock. Now, since the BP is falling, there is also possibility that the compensatory mechanisms in the body will kickstart. There can be a reflex vasoconstriction, and this reflex vasoconstriction can then result in the same patient to develop rather a spike of blood pressure. So lots of time in the textbook you will read the word wide fluctuations of blood pressure can be seen in patients of Guillain-Barre syndrome. Why these wide fluctuations of blood pressure are occurring is what I explained to you. Initially there will be features of neurogenic shock, bradycardia, hypotension, and then the sympathomimetic drive will increase. The remaining system is still functioning, right? I said patchy demyelination, I said damage only from T1 to T4. The remaining sympathomimetic drive in the body is working, so it will cause a peripheral vasoconstriction that can even spike the blood pressure of this patient. So you need to monitor BP of these patients very aggressively. And I repeat once again, don't be under impression that this is a pure motor disorder causing only a paralysis. It can even have sensory implications. If the person can talk, if he can't talk, if he presented late, then obviously he cannot tell you about the sensory complaint. But if he comes early and he can talk, he will definitely talk about sensory complaints. If you ask him what is the problem, not only will he tell you that I can't move my legs, he will also try to tell you that I'm having pain in my muscles. So what is the kind of pain in the muscles he will experience is like if you do exercise after a long time. Like most of doctors, like you guys are preparing for an exam, so most of the time you hardly get time to exercise. You just keep on sitting at one place listening to lectures and keep on giving tests, etc. So if I ask you to do some running for 1 kilometer, most of you will either refuse, or even if you manage to do it, after 1 kilometer running you would be having pain in the muscles. So a similar kind of pain that comes in the muscles after exercise is the kind of pain that will be experienced by these patients. I repeat the fact once again, the sensory complaints of these patients would be pain in the muscles of a similar nature as comes after doing a prolonged exercise or exercise that is done after a substantially long duration. Some patients might even tell you that they can feel some tingling sensation in the extremities. Remember, I told you peripheral nerves are involved, and because of peripheral nerve involvement, there can be paresthesias developing in the patient as well. So, these are the usual manifestations that you will encounter in these patients. And then I want you to remember that bladder and bowel may be spared in this condition. The reason is, again, I highlighted earlier that there is a segmental demyelination. So it is not a hard and a fast rule, but in majority of cases of Guillain-Barre syndrome, you can be having demyelination in the cervical spine, thoracic, lumbosacral. But as you go down towards the sacral S2, S3, S4, usually S2, S3, S4 may be spared, because of which bladder and bowel are spared and the hygiene component will be maintained in these patients. I'm just writing the word plus minus after this to say that it's not a guarantee that it's going to happen in all the cases, but yes, bladder bowel being spared is one of the features that you encounter in Guillain-Barre syndrome, whereas subsequently I will teach you transverse myelitis, in which case almost all cases or majority of cases will be having a development of bladder bowel involvement. I repeat the fact once again. In transverse myelitis question, bladder and bowel involvement is usually always almost seen, whereas in this case it may or may not be seen. So that minor technical difference should definitely be kept in mind while attempting case-based scenarios. And most of the time we'll describe a young chap suddenly woke up with inability to move his legs, and that's when he tried to get up and he fell down flat, and his mom has come over, his dad has come over, and they're trying to massage his legs and worrying about what's really going wrong. And the illness can be progressing so fast that within a couple of days, you see, the upper limit of progression, as I'll tell you in the diagnostic criteria, is up to 4 weeks. But the point is, this illness can actually progress over a couple of days, and a patient might become dependent on a ventilator till you get rid of the harmful antibodies which are present here. I'll talk about the treatment part subsequently. But if you get the clinical domain right, especially the combination of motor plus sensory plus autonomic manifestations which are going to occur in these patients, will definitely help you in solving the questions on this topic. If he says which is the earliest manifestation, then your answer would be distal areflexia, because first in this patient it is the ankle jerk that is lost, then it is the knee jerk that is lost. So the paralysis goes from bottom upwards. So let me just make you revise what are the manifestations of the disease that I've just explained to you. I said initially the paralysis will occur in the muscle supplying the ankle joint. Then there's going to be paralysis related to muscles of the knee joint. Then the hip joint muscles would be affected, and that is why I was saying that he won't be able to stand. The bad news is that even the arms can be involved in this case. Then unfortunately there can be involvement of even the diaphragm. There can be neck floppiness, and there could be even facial paralysis occurring in the patient bilaterally. Bilateral seminal paralysis will occur. I used this term earlier also, but I'm repeating it. There would be ascending, symmetrical. Please remember, the paralysis in the left leg will be equal to the paralysis in the right leg. If you check the power of muscles in the left leg versus power of the muscles in the right leg, both would be affected in an identical fashion. So ascending symmetrical flaccid paralysis is the term that I want you to remember for this particular topic. I mean, very characteristic. In contrast, I'll just use a different color to mention that when it comes to poliomyelitis, though poliomyelitis has been eradicated from India, it is still present in Pakistan and Afghanistan. So if you read about descending paralysis of asymmetric nature, then one of the differentials that always have to be kept in mind would be that of poliomyelitis. You see, descending paralysis is what you read even with botulinism also, no? You read that even with diphtheria. There are three important causes of descending paralysis that I have just mentioned before you: poliomyelitis, diphtheria, and botulinum toxin. And yes, asymmetrical per se, especially from a developing country perspective, you should definitely keep a watch for answer as poliomyelitis.
Question 22. An HIV-positive man presents with a high-grade fever. Examination reveals a positive Kernigh's sign. CSF shows reduced glucose, increased protein, and increased leukocytes. A diagnosis of cryptococcal meningitis is made. What is the appropriate management for this patient? Here are the options. A. Vancomycin. B. High-dose fluconazole with flucytosine. C. Voriconazole. D. Liposomal amphotericin B. And the correct option is D. Liposomal amphotericin B. Here is the explanation.
True. First is obviously Cryptococcus. The best test for diagnosis of cryptococcal meningitis is not India Inc., but it is a CSF ELISA for cryptococcal antigen, CRAG as they might use it. CSF ELISA for cryptococcal antigen. For treatment of this infection, the first line treatment would be liposomal amphotericin B, which can obviously damage the kidney, so KFT monitoring should be done with the 5-flucytosine.
Question 23. A patient presents with complaints of sudden onset headache, palpitation, and profuse sweating. The patient has had multiple similar episodes in the past. During these episodes, the patient's blood pressure is elevated. A 24-hour urinary metanephrine is elevated. What is the most likely diagnosis? Here are the options. A. Addison's disease. B. Renal artery stenosis. C. Pheochromocytoma. D. Hyperthyroidism. And the correct option is C. Pheochromocytoma. Here is the explanation.
Please remember the fact that you need a high index of suspicion for diagnosis of pheochromocytoma, so we will now talk about workup of these patients. The test that I would like to highlight for this person is a 24-hour urinary evaluation. The test that we will do is called as 24-hour urinary fractionated metanephrine levels. In the options, 24-hour urinary catecholamines will also sound very appealing to you. Though 24-hour urinary catecholamines will be written in the question, do not mark on it, because you see catecholamines have a limited duration. After that they get disintegrated in the sample. So like in India, where facilities are not so great, you might take the sample, but it might be tested maybe the day after or maybe subsequently. So by the time the sample is tested, the catecholamines have been degraded. So it's a good idea to actually measure the end products of catecholamine metabolism, and the end products of catecholamine metabolism is fractionated metanephrine levels. I want you to remember the fact that the best screening test for diagnosis of pheochromocytoma is 24-hour urinary fractionated metanephrine levels. This is to be answered superior to a 24-hour urinary catecholamine values. I repeat the statement once again. Urinary catecholamines will look very tempting, but as I explained to you, they have a limited duration of action. So by the time the sample is processed, they're already degraded. The value might come out to be falsely normal also.
Question 24. A 26-year-old male patient, an accident victim, started developing difficulty in breathing. On examination, his BP was 80/40 mmHg and pulses were feeble, non-pulsatile JVP with an absent Y descent, and heart sounds were muffled. What is the most likely diagnosis? Here are the options. A. Constrictive pericarditis. B. Cardiac tamponade. C. Acute pericarditis. D. Cardiac failure. And the correct option is B. Cardiac tamponade. Here is the explanation.
Is because the concept here is very simple and straightforward, that in a MCQ of cardiac tamponade, he can ask you the following findings. As in any cardiology question, he will ask you regarding pulse, blood pressure, heart sounds, and jugular venous pressure. This is what we have learned. The pulse in these patients will tend to disappear in the phase of inspiration, or the technical definition will be that the difference between inspiratory and expiratory pressure will be more than 12 millimeters of mercury. Because this patient will be having severe hypotension, obstructive shock, you have to go in for a echocardiographic guided pericardiocentesis. IV fluids will be futile. They will not help in increasing the blood pressure, rather they will worsen the condition of the heart. Because the heart sounds in this patient will be sounding distant, there's a lot of blood outside the heart, there is a malignant pericardial effusion of large size, so I can say muffled heart sounds. The JVP of this patient is what we discussed. One, the Y descent that happens in a normal person would be absent, or another way to describe this would be, because there is no fall, I might say non-pulsatile. You see, the logic is, normally you have pulsations in the JVP, it falls during inspiration. This fall will not be present in this patient because pressure is so high. It's literally crushing of the heart from outside. The query from most doctors is that you are saying pressure around the heart is more, so it should be causing a rise of JVP. We should be getting a Kussmaul sign. See, what I said for Kussmaul sign was it is a rise. But in this particular case, that pulsations cannot be present. The pressure is so high that the pulsations will totally be absent, because you will not be able to pick up the fall or the rise of it. So that's why I said non-pulsatile elevated JVP, because most guys have this query, sir, why is it non-pulsatile? It should be rather, it should be elevated and pulsatile. No guys, cardiac tamponade is a condition where there's a crushing of the heart to such a magnitude that the pulsations will disappear. Pulsations occur in normal person, but here because of the pressure aspect, the pulsations will tend to disappear. So that's a very characteristic statement I have said, a very powerful statement that's to be remembered. Non-pulsatile elevated JVP is a feature that you see with superior vena cava thrombosis and patients of cardiac tamponade.
Question 25. A known hypertensive patient is brought to the ER with palpitations and breathlessness. On examination, his BP was 220/140 with signs of stroke. Which of the following is used as a first-line drug to manage this patient? Here are the options. A. Phentolamine. B. Nicardipine. C. Mannitol. D. Prazosin. And the correct option is B. Nicardipine. Here is the explanation.
Development of stroke, like he mentions, person has had a ischemic stroke, then there can be two possibilities. Person is gonna receive thrombolysis or not. You very well know that we use retaplase within the window period of 4.5 hours. So if a person comes within the window period, obviously thrombolysis has to be done. So when should you do thrombolysis? You must always ensure the fact that the blood pressure of the patient when thrombolysis is to be initiated should be less than. In fact, in the exam, he has said blood pressure more than how much, listen to my words carefully, blood pressure more than how much would you not do thrombolysis? Blood pressure, if more than 185/110 millimeter of mercury, you are not supposed to do thrombolysis. Immediately, first lower the BP, then do thrombolysis. And to lower the BP, what drug would be used in this case? Then the answer here would be given as nicardipine. In fact, I'll just show you the reference from CMDT also in a while. But you see, why not sodium nitroprusside? Because nitroprusside is a very efficacious drug, but it causes a fast fall of blood pressure. Because of this fast fall of blood pressure, what happens is that the cerebral perfusion pressure can be affected. Cerebral perfusion pressure is a difference of mean arterial pressure minus intracranial pressure. If you lower the MAP, CPP will also get lowered, and you are rather causing harm to your patient, because if you decrease the blood supply to the brain, it will contribute to brain infarction. The chap came to you with already a ischemic stroke, and if you cause further worsening of blood supply to the brain, the ischemic stroke will definitely worsen also. So we will be more comfortable using drugs like nicardipine and clevidipine. Advantage of these drugs is you can titrate how much millimeter fall will occur over next couple of minutes. You need to titrate the fall of blood pressure to a controllable value, lower the value to this particular statement of mine less than 185 by 110. In MCQ he deliberately asked more than how much, so the answer will be more than 185 by 110. I'm not going to do a thrombolysis. First I will lower the BP. The word is, and that's why I'm highlighting the statement. I mean, any chap who's a candidate for thrombolysis, he has presented in first 4.5 hours. I will first lower the BP to this particular threshold, and then I can do thrombolysis in the person, because if I do thrombolysis at a value higher than this, he has said, God forbid, thrombolysis also has a side effect, no? IC bleeding. He says, God forbid, if somebody, God forbid is just to exaggerate, if somebody is going to have a CNS bleed and blood pressure is on the higher side, then the bleed will worsen, no? So you need to remember, blood pressure more than 185 by 110 in a guy who's a candidate for thrombolysis, who's landing up in your casualty in the window period for thrombolysis.
Question 26. What is the most commonly seen pattern in chest CT of patients affected with COVID-19? Here are the options. A. Interlobular septal thickenings. B. Air bronchograms. C. Ground glass opacity. D. Crazy paving pattern. And the correct option is C. Ground glass opacity. Here is the explanation.
For any droplet-based transmission infection, we should be knowing regarding the RO number. You see, when you look at RO number, RO basically would mean the reproductive period for any infection per se. Then for COVID-19, the initial report that came from Wuhan, from where the disease actually spread, it was documented the RO number was 2.56, that one case will infect these many number of patients. Subsequently, the disease spread due to Chinese tourists to Italy, and the data that was coming from Italy in March 2020 was about a RO number of 7. It is that value of RO of 7 that actually sent the Indian government into a panic mode, and the government of India introduced a lockdown in March 2020. But subsequently, it has been documented in Indian reports that the RO number of COVID-19 is something in the range of 1.29, and our objective with respect to COVID-19 will be mainly to bring it to less than 1, because that is when you break the chain of transmission. Well, when it comes to COVID-19 pneumonia, I want to highlight the radiological finding is always GGO, that is ground glass opacities, which are mainly found in the lower lungs bilaterally.
Question 27. Following gastrectomy, the patient is most likely to have which of the following? Here are the options. A. Folic acid deficiency. B. Vitamin B12 deficiency. C. Gastric ulcer. D. Constipation. And the correct option is B. Vitamin B12 deficiency. Here is the explanation.
The bottom line is that you are gonna be having large gut flora. Mark my words there. Large intestinal bacteria are migrating into the small intestine and are causing mucosal damage. The end result would be a B12 malabsorption. One of the highlights of this condition is, apart from mucosal disease of the terminal ileum, which will contribute to nutrients being malabsorbed, B12 deficiency will definitely be a feature of this condition, because that's the primary site of absorption of B12.
Question 28. Most common sustained tachyarrhythmia. Here are the options. A. Inappropriate sinus tachycardia. B. Junctional premature complexes. C. Atrial fibrillation. D. Atrial flutter. And the correct option is C. Atrial fibrillation. Here is the explanation.
I've already explained to you that the overall most common sustained tachyarrhythmia in clinical practice is atrial fibrillation. And even if he changes the question and says what's the commonest tachyarrhythmia in a hypertension patient, geriatric patient, or even cardiomyopathy patient, he might say hypertrophic cardiomyopathy, dilated cardiomyopathy. The answer is still atrial fibrillation. You see, sudden death in hypertrophic cardiomyopathy, it's ischemic ventricular fibrillation. But if it uses the word sustained tachyarrhythmia, then even in a hypertrophic cardiomyopathy, the answer to all of these questions is atrial fibrillation.
Question 29. Preferred biochemical markers in patients presenting with myocardial infarction. Here are the options. A. Myoglobin. B. Cardiac-specific troponins. C. CKMB. D. All of the above. And the correct option is B. Cardiac-specific troponins. Here is the explanation.
CPK-MB was the answer when I was a student at your age. They used to ask what is the best test for identification of myocardial infarction. We used to answer CPK-MB gross elevations. The problem is that CPK-MB will rise, but the rise might take as much as 4 to 6 hours. Whereas when it comes to troponins, the rise will occur relatively earlier, that is about 3 hours. And at this junction, I also want to say, like in Delhi, there are so many cardiology hospitals. Like at the moment where I'm recording, 3 kilometers away from here would be Max Hospital. Maybe 7 kilometers here from here will be Fortis, and maybe AIMS next door. So point is, patient will have so much of choice whether I should go to, if somebody is having chest pain, should I go to AIMS? Should I go to let me say AIMS Hospital, or should I go to Max Hospital or Fortis Hospital? So my point here is that if a person will come early, then if he comes lesser than or earlier than 3 hours, so when you read the word serial troponin I, it means the fact that one, you can check the value of troponin I at admission, and you can repeat it the same after, let me say, 3 hours or maybe as late as 6 hours. So if it's a genuine case of MI, obviously the later values will be elevated, but I'm not saying that you will wait for the values to be elevated and then starting treatment. The first test to be done for evaluation of any person is ECG. ECG has its own limitations that I'm going to tell you, but at the moment the message is that if a person came with chest pain at rest, if ECG is showing evidence, we are not going to wait. Like somebody came within 1 hour, I'm not going to wait for the TROP-I values to become grossly elevated and then okay, it is MI. If ECG is showing finding, fine. That is why it is written in the textbook, ECG and or biomarkers. I mean, any of the two, if it is positive, you can start the treatment of the patient. Well, there will be no questions on the peak values per se, because the peak values are pretty constant. All of them would be peaking at around about 24 hours, but fall definitely will vary. For CPK-MB, the fall occurs by the third day, which explains the fact that why I was saying that if somebody suffers from a MI again on the fifth day, or let me say the fourth day, then CPK-MB will rise. CPK-MB values came down, then it will rise once again. But when it comes to troponin T or troponin I, they remain elevated for relatively longer duration. For troponin T, it is 10 to 14 days. For troponin I, it is 7 to 10 days. If they ask you to select between trop T and trop I, then select trop I, because quantification of this can easily be done. The highly sensitive tests that we have, we can quantify what is the magnitude of rise. Is it 0.04 or lesser? That is normal. If it is 0.05, 0.06, yes, the ischemia part is very severe and injury will definitely occur subsequently. And if there's an injury, then values will always become double and even higher than that, depending upon how much blood vessel and which critical blood vessel has been involved.
Question 30. A 10-year-old boy comes to the office with complaints of swelling of his ankles and puffiness of his face. His examination reveals a positive puddle sign. His laboratory investigations show 3+ proteinuria and no hematuria. Which of the following is the most likely diagnosis? Here are the options. A. Membranous nephropathy. B. Membranoproliferative glomerulonephritis. C. Minimal change disease. D. Focal segmental glomerulosclerosis. And the correct option is C. Minimal change disease. Here is the explanation.
And I have this 4-year-old girl, and the mother says that she woke up with puffy eyes to the level that the child is not even able to open the eyes properly. Then she says a very surprising fact. She said edema disappeared. So first time when I read about it, I thought that maybe, some kind of an allergy to food item could be present, or maybe an insect bit the kid, allergic insect bite reaction could be present, which is contributing to this, I would say, very significant puffy eyes in the child. But why the edema had disappeared from the mother's perspective was that this edema will then migrate to the genitals, and therefore this girl child can be having difficulty in urination as well. Then subsequently the edema will migrate to the feet. So in the first consultation, you might not get the diagnosis of nephrotic syndrome right. But then as you follow up this case, you will notice that the mother is saying, sir, the weight of the child is increasing. And at festival time, like they had brought some clothes for the child. So they say that like we brought a skirt for the child, girl child, or for a boy, they brought a suit for a child. They say, sir, that dress we are not able to put up at festival time. So I don't know. I mean, suddenly the child has become bulky, or suddenly the child has become relatively heavy. And you will also notice that if the child is brought late, they could also be having pleural effusion and ascites. Why that is so is because there would be a urinary loss of albumin, so oncotic pressure will reduce, and every time there is going to be reduction of oncotic pressure, there's going to be development of a transudative variety of pleural effusion. This pleural effusion, guys, will be because it is transudative bilateral, and the amount can be substantial to contribute to breathlessness in the child also. So lots of time you would have noticed minimal chain disease children having breathlessness, and you are wondering, I mean, this is a puffy child, what really happened? It's the pleural effusion component which is present, and ascites will contribute to abdominal distension, and you can understand from abdominal distension why the new dress that the mother had bought for festival time for the child is not fitting. These are the standard reasons why these children would be brought over to you, and now we want to discuss what will be the workup of this child. The first test that I'll do in any kid who's puffy would be to go in for a KFT, and kidney function test in these patients will be normal. Blood urine nitrogen is either normal to low, serum creatinine is also normal in these patients. Then I'm going to subject the urine of this patient to both a routine microscope examination as well as a quantification of the protein. So on urine microscope examination, the examiner will say the word oval fat bodies. I have already told you lipiduria can be a feature that could be present in all varieties of nephrotic syndrome. I'll be quantifying 24-hour urinary protein for these patients. The magnitude of this will definitely be increased. Now, since I'm talking about a child in this case, if he's 4 years of age, 5 years of age, the cutoff would be same as adults, 3.5 grams in a 24-hour period. But if I talk about infants per se or in the first year of life, it would be 40 milligram per meter square of body surface area. Also, in the urine of these patients, the protein that is lost is mainly low molecular weight protein. That is going to be albumin, and because of this albuminuria, the term that will be used to describe minimal chain disease will always be selective proteinuria.
Question 31. Investigation of choice of diagnosing celiac disease is? Here are the options. A. Small bowel biopsy. B. Anti-endometrial antibodies. C. Blood picture. D. Biochemical test. And the correct option is A. Small bowel biopsy. Here is the explanation.
Coming to the investigation of choice for this condition, we will be doing a small intestinal mucosal biopsy. Well, this test will have to be done 2 times in the patient, one initially and then would be repeated after 4 to 6 week period.
Question 32. A 38-year-old male presents with fever, cough and anorexia. He is sputum positive for AFB. In order to consider this as a case of XDR-TB, which of the following should he be resistant to? Here are the options. A. Resistance to at least INH and rifampicin plus other drugs. B. Resistance to any of the 3 first-line drugs. C. Resistance to all first-line drugs and any 3 second-line injectable drugs. D. Resistance to at least INH rifampicin plus any quinolones plus at least 1 injectable second-line drug. And the correct option is D. Resistance to at least INH rifampicin plus any quinolones plus at least 1 injectable second-line drug. Here is the explanation.
In India, we are having a spurt suddenly in cases of XDR tuberculosis. Well, the definition of XDR tuberculosis would be the patient will be having resistance to both first line as well as second line drugs. That is resistance to one of the main weapons that we have, isoniazid rifampicin. Along with this, there will also be resistance to fluoroquinolones. That's going to be molecules like levofloxacin or ofloxacin. You would notice mainly levofloxacin is the one that is used, and once a day tablet is more than sufficient. Along with this, person will be having resistance to any of the 3 injectables that I'm going to write here. So SLI means that we are having resistance to any one of the 3 second line injectables. These second line injectables can be remembered as ACK. Alphabet A would stand for amikacin. Again, the advantage of amikacin is once a day shot that is required. Then C would stand for capreomycin and K would stand for kanamycin.
Question 33. In restrictive lung disease, here are the options. A. FVC is high. B. FEV1 is high. C. FEV1 FVC is high. D. All of the above. And the correct option is C. FEV1 FVC is high. Here is the explanation.
Right from the first day into medical school, we start learning about obstructive airway disorder and restrictive airway disorder. So let me just refresh your memory related to what we have already studied regarding these kind of disorders. The prototype disorder that I'll use for obstructive would be either COPD having bullas and blebs or bronchial asthma having a narrowing of the airways. For restrictive, we can take any subtype of interstitial lung disease, whether it be UIP, whether it be non-specific interstitial pneumonitis, or even cryptogenic organizing pneumonia. In obstructive airway disorders, simple English would tell you that FEV1 of the person will dramatically be reduced. I mean, normal FEV1 should be more than 80%. In this case, it would be lesser because of bronchospasm. What is going to happen to FEV1 in restrictive airway disorder? You see, there is pulmonary fibrosis. The lung has become relatively smaller, but as such, there is no obstruction present. So what is going to happen to FEV1? FEV1 of the patient will still be reduced. Well surprised. Why guys it is reduced is because if the lung will become smaller, then small lung will be able to push less air out of the lungs. Here I'm not saying any bronchospasm, I'm not saying any airway obstruction, I'm not saying any extrinsic compression on the airways from outside. All I'm saying is if the lung is going to be having less inside, less would definitely be going out. So reason why FEV1 is lesser in asthma is explained by the bronchospasm component. But on the right hand side for restrictive lung disease, guys, the reason why FEV1 is lesser, you need to appreciate that is lesser because it's a smaller lung. Therefore, FEV1 alone cannot differentiate between obstructive or restrictive lung disorder. So what the physiology people did was that they divided the whole thing, the mathematical value of FEV1 by total lung capacity. Now let us see how the mathematical domain will change for both left as well as the right side. Let's look at it from a fresh perspective. On the right hand side, I am saying FEV1 is already lesser, smaller lung. But because there is fibrosis, so total lung capacity will be less than 6 liter. Now if you look at the mathematics here, numerator is also reduced and the denominator is also reduced. So therefore there's a possibility that this ratio may be normal, or if there's going to be disproportionate reduction of TLC, then the value mathematically can increase also. Well guys, I am teaching you at the moment a term by the name of timed vital capacity. Timed vital capacity can be normal or significantly increased in a patient of restrictive airway disorder. But when it comes to persons of COPD asthma, see what happens in these patients is a development of air trapping. Because of the air trapping, the residual volume in these patients is increased, the lungs are expanded and the TLC can be more than 6 liter. So what is going to happen to time vital capacity? On the left hand side, guys, numerator is going to be lesser due to bronchospasm and denominator is increased because of air trapping. I repeat that again. The numerator FE1 is lesser because of obstruction. The denominator is increased primarily because there is going to be air trapping in this person. So the end result is that in this patient, the ratio will be reduced. In fact, the main message, the main carry home message from this particular slide is timed vital capacity can be used to differentiate obstructive and restrictive airway disorders in a sense that it is reduced in asthma and can be normal to increased in restrictive airway disorder.
Question 34. Obstructive lung function is seen in which of the following condition? Here are the options. A. Obesity. B. Kyphoscoliosis. C. Pleural effusion. D. Asthma. And the correct option is D. Asthma. Here is the explanation.
Obstructive airway disorder and restrictive airway disorder. So let me just refresh your memory related to what we have already studied regarding these kind of disorders. The prototype disorder that I'll use for obstructive would be either COPD having bullas and blebs or bronchial asthma having a narrowing of the airways. For restrictive, we can take any subtype of interstitial lung disease, whether it be UIP, whether it be non-specific interstitial pneumonitis, or even cryptogenic organizing pneumonia.
Question 35. A 49-year-old male presents with recurrent episodes of watery diarrhea, dehydration, hypokalemia, and achlorhydria. Which of the following neuroendocrine tumors can be responsible for these symptoms? Here are the options. A. Insulioma. B. Somatostatinoma. C. Vipoma. D. Glucagonoma. And the correct option is C. Vipoma. Here is the explanation.
Now, VIP is a 28 amino acid peptide which is going to be produced from the F cells of the pancreas. Like you are aware, alpha cells produce glucagon and then beta cells produce insulin, delta cells produce somatostatin. It is the F cells that would be producing VIP. This tumor is mainly located in the pancreas, but sometimes can be having extra pancreatic sites also being asked. The surprising answer for this extra pancreatic site would be this VIPoma, or excess of VIP can be also with respect to carcinoid tumor. And then in pediatrics, we have a tumor by the name of ganglioneuroma. So previously I was talking about tumors which are originating primarily in the pancreas, neuroendocrine, but here I have spoken regarding what they can ask you about is extra pancreatic sites as well. VIPoma is found in the GI tract, but is also found in the CNS. So just like I said for somatostatin, both CNS and GIT, same here for VIPoma also. And this VIPoma can also contribute to development of vasodilation, because that's one of the physiological effects if it is released from central nervous system apart from release from the intestine. And because of this vasodilation component, one very characteristic feature that can be written in the MCQ is flushing episodes. The first time you read about flushing episodes is carcinoid tumor or carcinoid syndrome, but now I told you one more reason where flushing episodes could be described in the question. Let's look at why the clinical presentation or how it will be given to you. The GI manifestation will be that of watery diarrhea, that would be secretory diarrhea in this case. So the consistency of the stool would be rice water stool, just like in a case of cholera. Therefore, the description in the MCQ will most of the time give a hint to you by saying the word pancreatic cholera. That is just to highlight that this is a pancreatic tumor and it is contributing to stool consistency, which would be identical to that you see in a routine case of cholera. And because this is secretory diarrhea, therefore the osmolar gap in this particular case will be usually less than 50. I'll tell you the formula for osmolar gap also on the subsequent slide. But how is secretory diarrhea asked in MCQs? Either he will say diarrhea which is non-responsive to fasting, because osmotic diarrhea anyway will respond to fasting, but secretory diarrhea is non-responsive to fasting. Or he will talk about stool osmolar gap, formula coming up on the next slide. I'll just give the mathematical value here, because the stool is going to be rich in electrolytes, as a result of which the osmolar gap will usually be less than 50, whereas in osmotic diarrhea it is usually more than 100. Let's look at other features that can be seen. Because there is diarrhea, there will be hypokalemia component that can explain the muscle cramps of these patients. So that's the first time in a neuroendocrine tumor we are reading about an electrolyte imbalance. I also told you because this tumor can cause release of VIP, which has action of vasodilation. So flushing episodes can also be given, which can obviously cause you to think in terms of carcinoid tumor as well. But in carcinoid tumor, you would be having asthma-like illness. You will read about extensive pruritus in a patient, cardiovascular involvement in the form of tricuspid insufficiency, pulmonary stenosis. But this is definitely not going to talk about these. It will rather talk about achlorhydria present in these patients, and then hyperglycemia and even elevated calcium. Point number 5 is rare but is important from the exam perspective, that hyperglycemia can be seen with VIPoma and hypercalcemia as well, because they like to ask couple of minimal, or I would say minor aspects also.
Question 36. A 5-year-old child presented with recurrent respiratory infections with thickened sputum. Chest X-ray showed bronchial wall thickening. He has been suffering from steatorrhea since birth. Which of the following is the diagnosis? Here are the options. A. Hyaline membrane disease. B. Cystic fibrosis. C. Alpha-1 antitrypsin deficiency. D. Malabsorption syndrome. And the correct option is B. Cystic fibrosis. Here is the explanation.
So let us now summarize the diagnostic criteria for cystic fibrosis. First of all, you should be having presence of typical clinical features. The typical clinical features would be respiratory involvement, which could be in the form of development of either features of COPD initially. Then there could be development of suppurative lung disease in the form of bronchiectasis in the patient, which will obviously take some time to occur. The gastrointestinal manifestations can be in the form of first meconium ileus, which is the early one, and subsequently development of malabsorption syndrome. The malabsorption syndrome can range from something like osmotic diarrhea to steatorrhea occurring in a patient, and the genitourinary manifestations are in the form of a cervical mucus plug or azoospermia in the patient. So if you are having these typical clinical features, or he says there is a history of cystic fibrosis in the sibling, that's very understandable, autosomal recessive consanguinity given in the question. So history of cystic fibrosis in the sibling, or a positive newborn screening test.
Question 37. The patient is identified as having a tumor in the ileum and leading to urinary 5-HIA being elevated. What is the diagnosis? Here are the options. A. Carcinoid tumor. B. Neuroblastoma. C. Leukemia. D. Chromatophenoma. And the correct option is A. Carcinoid tumor. Here is the explanation.
Pheochromocytoma will mainly be producing norepinephrine, but if it is Sippel syndrome, then it is epinephrine producing, and the third hormone which is present is dopamine. Whereas when it comes to carcinoid tumor per se, it will be 5-HT derivatives that will be in the picture. The 5-HT derivatives will be either in the form of serotonin or will be histamine. Now you need to understand and remember the fact that the amino acid which is required for synthesis of these 5-HT derivatives is tryptophan. And tryptophan is also required in our body for synthesis of niacin. The problem in this person of carcinoid tumor / syndrome is that the tumor will misuse this tryptophan. All the tryptophan will be diverted, mark the words there, all the tryptophan will be diverted towards the synthesis of 5-HT derivatives which are being produced in excess than what is required. So if you will waste tryptophan in synthesis of something which is not required in such a substantial amount, then the availability for niacin synthesis will become lesser. You see, tryptophan produces niacin, produces 5-HT derivatives in you and me, not a problem. Here there is a wastage. So the availability for niacin synthesis will be lesser, and because the availability for niacin synthesis will be lesser, this will contribute to development of pellagra as a manifestation in the person. So remember, MCQ wise, pellagra as a manifestation is seen or written in MCQs of carcinoid tumor, but no such aspects related with respect to pheochromocytoma. Another aspect which is always asked for carcinoid tumor / syndrome is cardiovascular implications. The cardiovascular implications have been touched in cardiology section, but I would like to reiterate the statement. There are two valvular lesions that can be seen with carcinoid syndrome, that is TIPS. In TIPS, TI would stand for tricuspid insufficiency, that will contribute to pansystolic murmur. And then would be PS, that would be pulmonic stenosis, that will contribute to ejection systolic murmur. So even the information of murmurs can be written in a question. And remember that carcinoid tumor results in a syndrome. Your syndrome would involve the cardiovascular system also. The most common site for carcinoid tumor is controversial. It is bronchus, it could be ileum, it could be rectum or appendix. Why I called it controversial is because the surgeon will say appendix, whereas I am quoting Harrison here that mentions the primary site of carcinoid tumor as the bronchus. Remember the fact that when it comes to pheochromocytoma, the primary location will be adrenal medulla. However, if he does not want to know about adrenal medulla, he would love to ask you regarding the sympathetic ganglia present near the inferior mesenteric artery that is harboring the tumor, which was written as or was discussed as organ of Zucker-Kendall. Now we will compare the clinical features of the two. The clinical features of carcinoid tumor will mainly revolve around excess of serotonin contributing to secretory diarrhea. Please remember, osmotic diarrhea is responsive to fasting, whereas secretory diarrhea is non-responsive to fasting. So either he will write the word secretory diarrhea or he will say diarrhea non-responsive to fasting. There will also be asthma-like symptoms developing in this person. Asthma-like symptoms because of histamine. Histamine causes bronchospasm, but I'm not writing only asthma. I'm saying asthma-like symptoms because asthma could be triggered by exposure to pollen grains or dust or allergens. But in this case, this guy is sitting at home and there is a wheeze coming from the chest of this guy. Histamine will also contribute to activation of H1 receptors in the skin, contributing to extensive itching, pruritus. Then histamine will activate H2 receptors in the stomach that can contribute to excess acid production. Therefore, epigastric pain or gastritis could be described in this patient. One of the very characteristic features that you will read in a multiple choice question of this topic would be flushing episodes. Please remember the fact that histamine causes vasodilation, so flushing episodes would be mentioned. Whereas for the right hand side, I've already sensitized due to PhD, that is palpitations, then is a headache, then is a diaphoresis. The headache is primarily due to hypertension. Either he will use the word paroxysmal hypertension or he might use the word episodic hypertension. So either of the two terminologies if written by you, you should understand that the question is dealing with pheochromocytoma. The test that is done on the left hand side was told to you even in the starting of this discussion, urinary 5-hydroxyindole acetic acid levels, HIAA levels. Whereas when it comes to the right hand side, the test that I taught you was 24-hour urinary fractionated metanephrine levels. I have already sensitized you to the fact that do not be prompted to answer as catecholamine levels. Then we talked about scans also. Though MRI abdomen is the preferred imaging modality, if it's not able to pick up, we can use a MIBG scan. Whereas on the left hand side, the scan that I'm using is Octrio scan.
Question 38. A patient presents with complaints of a morning time foul-smelling productive cough that is yellow in color. On examination, there is the presence of crepitation and clubbing. Which of the following lung diseases is likely to be present? Here are the options. A. Lung cancer. B. Bronchiectasis. C. Bronchial asthma. D. Pulmonary embolism. And the correct option is B. Bronchiectasis. Here is the explanation.
The clinical manifestation in the question can be deliberately made by the examiner look like that of chronic bronchitis. He will begin by describing, he may even say smoker. Now, because I want to simplify things before you, so I'm not saying the word smoker or former smoker. I'm saying this particular chap, he may be recovered from a pneumonia, multiple episodes of pneumonia due to any reasons, could be genetic as well. So there's a productive cough present. Then there's a bronchoria, and every time there is an exacerbation. In fact, just like in COPD you have exacerbations, like in asthma you have exacerbations. This is also an obstructive airway disease where you can be having recurrent exacerbations, and with every exacerbation what you will notice is that the purulence component will gradually keep on increasing. The secretions will become more fetid, much more foul smelling, so person will be having halitosis, bad smell from the mouth. He says that I brush my teeth regularly, but doctor, there's always a foul smell, and the sputum, especially in the morning hours, he produces very foul smelling purulent sputum. There would be breathlessness on exertion. When you auscultate this person, there would be crepitations or rales present. There can even be rhonchi present in these patients, though relatively less commonly. So I am just marking it here to say the fact that you can be having both crepitations and crackles in these patients. One of the I would say features that would be peculiar to bronchiectasis would be that these crepitations will mainly be focused to the lower part of the chest in majority of the cases, especially with respect to infection, especially with respect to microaspiration. So when I talk about chronic bronchitis, in chronic bronchitis I never said the word creps. In chronic bronchitis I was mainly focusing on rhonchi, but when it comes to this disease, I'm not saying that this is an absolute way, but yeah, if you pick up these minor words, I think that you will be more comfortable. Like in chronic bronchitis, there will be absolutely no clubbing. And just to set the record straight, because you'll be wondering, I'm saying this again and again, so we need to put it on in black and white here. Smoker, bronchoria, repeated exacerbations that make the sputum relatively much more, I would say, purulent. Rhonchi being heard in the patient, both inspiratory as well as expiratory rhonchi, but no mention of clubbing. You have to think in terms of, if this is the data given in the question, you would be thinking in terms of chronic bronchitis. On the other hand, if you read a question where you definitely find clubbing present, though it's found in only 3% of cases, but still it's after all a finding. So if you read about clubbing, then you have to give benefit of doubt to diagnosis of bronchiectasis, and resolution will obviously be done with the help of a HRCT in the patient. Because this is obstructive airway disease, it will contribute to hypoxia, so the person will feel tired all the time. There would be a weight loss, and subsequently cor pulmonale findings can occur in the patient. Cyanosis can be present even in these patients. That's why I said no. I mean, blue bloater. Blue bloater is chronic bronchitis, and even cyanosis can be found even in these patients as well. Subsequently, as the disease will progress, features of cor pulmonale, right ventricular failure, and pedal edema will occur in the patient, though with time, evolution of the disease, the severity of manifestations have become relatively lesser with respect to this disease.
Question 39. J-wave is seen in. Here are the options. A. Hypothermia. B. Heat stroke. C. High altitude pulmonary edema. D. Drowning. And the correct option is A. Hypothermia. Here is the explanation.
This is a soldier who's posted at Siachen Glacier and is suffering from severe hypothermia. His PR interval is prolonged, his RR interval is increased because hypothermia causes bradycardia. In the diagram, you can notice regarding presence of J wave, which is also referred to as Osborne wave per se. This is gonna be when the core temperature of the body is less than 35. You very well know 32 to 35 is moderate, 28 to 32 is moderate, and less than 28 is severe hypothermia, and gradual rewarming of the body would be required.
Question 40. Which of the following types of hypersensitivity reactions is seen in myasthenia gravis? Here are the options. A. Type 1 hypersensitivity reaction. B. Type 2 hypersensitivity reaction. C. Type 3 hypersensitivity reaction. D. Type 4 hypersensitivity reaction. And the correct option is B. Type 2 hypersensitivity reaction. Here is the explanation.
First on the agenda would be aspects related to myasthenia gravis, which is an example of type 2 hypersensitivity reaction.
Set a reminder to come back for a quick mock test on psychiatry. Do like the video and subscribe to the channel if you learned something new today. Till then, bye.